This Decipher score is probably the first one of these expression-based signatures um, to, well, the grid is built around the grid signatures, which is a compendium of several hundred signatures that have been published both in prostate cancer samples and other in cancer samples of other types. The Decipher was the first one. That was the test that was first had a clinical, a commercially, sorry, a reimbursed indication, and that was a prognostic, as I said earlier, developed as a prognostic test to develop time to metastasis in a very advanced group of patients. The initial work in Charted was interesting because there was a difference in effect in the PAM50 patients with docetaxel between basal and luminal B. And as I've said, the direction of the effect was consistent in STAMPEDE, but not large enough to meet our predefined thresholds. With Decipher, the initial look around the median didn't identify any signal of interest, but we did note that the upper quartile, so Q4, appeared to have a lower hazard ratio with docetaxel. We know Decipher captures proliferation amongst, it's a signature that captures level of proliferation, but other processes as well, including immune evasion. So there's a biological rationale why these tumors would be more sensitive to docetaxel. And given we had most experience with this signature, that's why that's the one that really was pulled out for the primary analysis. A very wide spectrum. That's what's really notable about prostate cancer, especially now with our better treatments. As I've said in STAMPEDE, about a quarter of patients are in remission after 8, 9, 10 years, ongoing remission, whilst 20-30% have sadly progressed and passed away within 2 years. There's a wide variability. That variability is associated with the volume of metastasis at presentation. So patients who have a large number, they have worse outcomes, but not invariably. And if you split by volume status, about 15% of the high volume are in remission at 8 years, close to 30% of the low volume. But that's clearly not capturing it all, and or volume at presentation, metastatic volume at presentation is not capturing it all. The other point I'll make is we also tested the signature in those locally advanced patients who had no distant metastasis on conventional imaging, and we see no difference in effect. So we're increasingly understanding that they are biologically different, and the Decipher signature, which predicts docetaxel benefit in metastatic patients, does not have the same interaction in non-metastatic patients. The trials we studied were ADT and ADT abiraterone. So the intensification was addition of abiraterone, and ADT docetaxel. So in those 1,000 patients, they received docetaxel. More recently, a number of trials have studied ADT docetaxel plus abiraterone or plus other AR pathway inhibitors. What we don't have currently is randomization to addition of docetaxel. That's what I was implying earlier. And the sort of triple therapy. So we know with triple therapy, so patients receive ADT, RP, and docetaxel, that's better than ADT and docetaxel alone. In no trial, not STAMPEDE, not any other, do we currently have ADT, RP plus or minus docetaxel. That's a treatment intensification question. we don't have randomized data for, although, as I implied, for the worst prognosis patients, that triple combination of treatment intensification is commonly used in clinical practice. Because of the uncertainty of the evidence, the guidelines are showing differences between amongst each other. I mean, most will mention triple therapy, and then so that's ADT, abiraterone docetaxel, or ADT docetaxel, plus another AR pathway inhibitor. But the strength of the guideline varies from only select patients to the majority of high volume metastatic patients. And it's that uncertainty that we aim to, or we want to address with this test, both in terms of increasing use of docetaxel patients for low volume patients who would benefit, but also allow a more tailored approach in the high volume patients.